Welcome friends to my channel Family Tutorials. Today we are going to learn a disease condition which is peptic ulcer. But before we start our learning, just I want to suggest one thing, that you can watch this video in 1.5x speed to save your time. Okay, and one another suggestion to you, that please go for the comments. That will definitely inspire me and will help us to go for the innovation and the addition of my content that will improve myself. Okay, let's start. So it is a peptic ulcer disease. Basically, it is a gastrointestinal disease condition. Now, what happens actually? Before we understand pathophysiology, let's go back to the physiology. So in stomach, there is one important digestive aid which is a gastric acid. It is responsible for killing the microorganisms, and also it is activating the various gastric enzymes, and through which it helps in the digestion. Now, this particular gastric acid is being released from the wall of the stomach, that is gastric mucosa, and specific cells available over there are parietal cells. So these parietal cells are responsible for the release of the gastric acid in the lumen of the stomach. So this basic fundamentals we will start our theory. Okay, so let's understand the etiopathogenesis of the peptic ulcer disease. Okay. So there are two particular factors. One is aggressive factors and another is protective factors. Now understand, gastric is basically acting as a sword with two edges. If the gastric acid is in optimum amount, it is helpful in the digestion for the killing of the microorganisms. But if it increases a lot, it harms the stomach wall. Okay, so this happens in the case of the peptic ulcer. So which are the aggressive factors? So one of the most important aggressive factors, harmful factors, that is the gastric acid itself. Apart from that, there are pepsin, bile acid, pancreatic enzymes. These are the different digestive aids which directly or indirectly increase the level of the gastric acid a lot, and through that they damage the wall of the stomach mucosa. Now on the other hand, we are having the protective factors. Now one question must come into your mind, how the stomach wall is getting safe, protected against the gastric acid. Gastric acid is highly acidic, and if the stomach wall is having the exposure to this gastric acid, it must be get destroyed a lot. So fortunately we are being gifted with a mucus. Mucus covers the entire lining of the stomach mucosa, and through that it avoids the direct contact of the acid with that of the stomach wall. Okay, so this is the paramount important moieties, we can say, components, that is the mucus. So main protective factors we are having in the stomach, that is the mucus, and another helping factors, that is bicarbonate. Obviously it is alkaline in nature, so it helps to neutralize excess of the acid. Bicarbonate. Another one, that is the prostaglandins. PG stands for prostaglandins. Specific one are E2 and I2. They are also responsible for increasing the synthesis of the mucus layer. And other are blood flow and nitric oxide. It is not nitric acid, it is nitric oxide. So these are the protective factors. Now in normal healthy individual, there is always a balance between aggressive factors and protective factors. And that is why our stomach as well as the duodenum is very safe. But due to some triggers, due to some predisposing factors, this imbalance occurs between the aggressive and protective factors, and those triggers are one of the most important: H. pylori, Helicobacter pylori bacteria, Helicobacter pylori bacteria, followed by NSAIDs, non-steroidal anti-inflammatory drugs. We will learn our pathogenesis in the context of this particular two factors. Other factors are also there, that is smoking, chronic cigarette smoking, stress. In the stressful condition, a person might feel that there is a heartburn, there is a esophagus a problem, there is acidity, those kind of the issues, oxidative stress, and of course the diet. Obviously spicy diet, coffee, cola, tea, these are some factors which aggravates the acidity and responsible for the gastric erosion further. Okay, so these all factors are responsible for damaging the gastric mucosa, and ultimately the erosion takes place. Okay, with these fundamentals we will try to understand our etiopathogenesis in context of two particular main factors. Once again, those are H. pylori and another is NSAIDs. let's understand the most common cause of the H. pylori induced peptic ulcer with its mechanism. Okay. So basically H. pylori is a bacteria. It is a gram-negative rod-shaped bacteria. So you can say it as bacilli. Okay. Now very important component of this bacteria is what? They are acid labile. They are highly sensitive towards the acid environment and they cannot survive in the acidic medium. Okay, but they are being gifted with one of the particular enzymes, that is a urease enzyme. Okay, so what urease enzyme does, it is responsible for the conversion of urea into the ammonia. So whatever urea is there in our gastric region, it takes that urea and converts into ammonia, and that ammonia surrounds the wall of the bacteria. So entire bacteria is getting protected, is surrounded by the ammonia wall, which is highly alkaline, so that bacteria is surviving. Okay, so this is one of the important features. Now let's start the sequence. So bacteria enters into the gastric system. So there is an entry of the bacteria. Okay, so major route is obviously upper oral route. Then although the bacteria are acid labile, with the help of the urease enzyme, they are able to convert urea into the ammonia and they can survive and further propagate. For that, for the movement of the bacteria, they are having flagella. So do remember this word, they going for the flagellar movement, flagellar movement. Then bacteria is having further opportunity to adhere, that is the attachment, adhere with the wall of the stomach as well duodenum, and that will be conducted by lipopolysaccharides. So lipopolysaccharides are the adherence tools which are have with the bacteria. After the adherence or attachment, the bacteria will release the toxins. Those are known as exotoxins. Major exotoxins are two, remember, CAG-A and VAC-A. CAG-A and VAC-A. Now understand the functions of the CAG-A. Major two functions are there. CAG-A is mainly responsible for decrease or diminished cellular integrity. See, stomach wall is having the epithelium, and those epithelial cells are tightly bound. So they are having a very high level of the integrity. So what this CAG-A does, CAG-A is responsible for the breaking down those junctions, those tight junctions between the epithelial cells. So this is how it decreases the cellular integrity. Another function, CAG-A is responsible for releasing various cytokines. Which are the important cytokines? Those are interleukin 8, interleukin 2, interleukin 6, TNF alpha, and even the interferon gamma. Okay, you can note down this. Interleukin 8 and others. Amongst this all, the most important one, that is interleukin 8. Interleukin 8 attracts the neutrophils. Okay, and neutrophil further releases various inflammatory agents. One of the important, that is a histamine, and histamine is very important. Histamine attaches with the parietal cells, and parietal cell is having the H2 receptor. So H2 receptor grab the histamine. H2 receptor grab the histamine and further responsible for the release of the gastric acid. So here what happens exactly? With the help of the CAG-A, there is a release of the interleukin 8, neutrophil, further the histamine, and ultimately the gastric acid release is getting increase and increase. So you can just correlate with that. Aggressive factors is getting increased, right? And that is why more chances for the damage and more chances for the erosion, right? Another one, that is VAC-A, and VAC-A is responsible for simply apoptosis. Okay, the damage of the gastric wall and especially the gastric mucosa. So the acid related erosion is getting worse and worse. Okay, so this is the main theory of H. pylori induced mucosal damage, or you can simply say it as peptic ulcer. Okay, second one, that is NSAIDs induced, non-steroidal anti-inflammatory drug. And what they do, these drugs are targeting one enzyme, that is COX, cyclooxygenase. And cyclooxygenase enzyme is responsible for the release synthesis of prostaglandins. Okay, now NSAIDs are targeting both subtype COX-1 and COX-2. But when it targets COX-1 enzyme, there are specific prostaglandins which are getting diminished, PGE2 and I2. PG E2 and I2. And remember the function of Pg, E2 and I2. Yes, you can remember. You have remembered that Pg, E2 and I2 are one of the important protective factors. Okay, so when they are getting down, what will happen? See, the level of HCl, that is the gastric acid, increases. The level of bicarbonate, which is a protective level, factors, it is getting low, and the level of the mucus is also getting low. So there is increase in the aggressive factors, there is a lowering of the protective factors, ultimately lead to what? Damage to the gastric mucosa, erosion and peptic ulcer. In addition to that particular mechanism, these NSAIDs are itself acidic. Okay, so they are responsible for increased acidity in the gastric environment and lead to the gastric mucosal damage. And on the top of that, when NSAID come at the level of the gastric mucosa and go for the absorption, they converts into ionized form. And ionized form of this particular drugs are also responsible for increasing the acidity, and they are directly harmful, they are directly toxic towards the gastric mucosa, and through this mechanism also the damage to the stomach as well, duodenum, takes place. So this is all about the peptic ulcer. We have learned the etiopathogenesis, aggressive protective factors, and main two pathophysiology of the peptic ulcer, that is being induced by H. pylori and NSAIDs. Okay, I hope this video is helpful for you. Okay, all the best. Thank you.